Time has finally come. I'm officially graduating anesthesia residency. It's kind of crazy. I started making videos in this room about a year ago. Here I am full circle, saying goodbye to this lovely call room and my last 24-hour call shift at Rhode Island Hospital. So my residency training started with 1 year of internal medicine and then 3 years of dedicated anesthesia training. Now this next year I'm doing my fellowship in critical care medicine with the hope of practicing both anesthesia and being a critical care attending in the ICU. I have learned a ton in these past 3 years, all about anesthesia, all about interpersonal skills, and all about how the operating room system handles itself. I would love to share a few clinical pearls and a few interpersonal pearls that I've learned throughout my time to hopefully give you some encouragement and give you some insight as to what you can expect if you're a new anesthesia trainee or someone who's already along this path. I'm going to do this video in 2 parts. This first part is going to be all about clinical skills and advice for how to be a good clinician, and then the second part is going to be interpersonal advice and how you can just work well with others, especially in a team-based setting in the operating room. So my first piece of advice is oxygen is going to be your best friend. We use oxygen before a patient falls asleep, while they're asleep, and after they wake up. Having patients breathe oxygen before they go off to sleep will basically buy you more time if you're struggling to get the airway in. Being able to play with the amount of oxygen that a patient is breathing during a surgery would allow you to increase the FiO2 that they're breathing and also allow you to increase the amount of oxygen molecules that are circulating throughout their bloodstream. And lastly, when you extubate a patient and you transport them to the PACU, having some supplemental oxygen on board basically allows you to maintain an adequate pulse ox as you're transporting the patient. My second piece of advice is keep your fresh gas flows cranked up until the surgeon makes incision. So the way that we keep patients from moving and we keep them asleep during surgery is by providing anesthesia through our vaporizer, which basically introduces anesthetic gases into the breathing system. And there's 2 ways we control how much gas is going into the breathing system. That's either turning up the concentration dial or turning up our gas flows. Now, keeping your gas flows turned up basically allows those whatever percentage of vaporizer you have turned on to reach a steady state much quicker than if you had your fresh gas flows turned off. And when you deliver those vaporizers or the anesthetic gas to the patient, it's going to first start off in the lungs, but where you really want it to go is to the brain. The problem is, once it saturates in the brain, then it starts going to other parts of the body like muscles and fat. And so even if you think that your patient is asleep when you first get them off to sleep, likely they still have the IV induction medications on board and their body hasn't gone through what we call redistribution, where all of this anesthetic gases is now going to all the other compartments of the body. But by keeping your fresh gas flows up, you're introducing more anesthetic molecules into the patient's body so they can reach a steady state before that surgical incision has happened. The concern always is if you turn your fresh gas flows off and you haven't allowed enough time for the anesthetic gases to reach a steady state in the body, by the time that the surgeon is ready to start their incision, the patient may not be deep enough and you may see patient movement if they're not paralyzed, or you may see a sympathetic surge in their hemodynamics, so tachycardia, hypertension, basically meaning that your anesthetic is light and they're not deep enough. My last piece of advice is expect yourself to miss some IVs here or there. Anyone who performs placing IVs obviously takes a lot of pride in being able to get an IV on the first time, getting to sink those small veins or get IVs in small veins that other people couldn't get. And people who perform this procedure on a regular basis, like nurses, anesthesiologists, we take a lot of pride in our IV skills. But when you're first starting off, expect that you're going to miss a few. Now, how do you handle these situations where you're missing your IVs? Well, first of all, bring more than one catheter with you so that if you do miss, you don't have to go chasing down another catheter. You just have another one with the supplies that you've brought over. Secondly, I would recommend starting as far away from the core of the body or as distally as possible. So starting in the hand is a good spot because if you miss, then you can basically work your way up the arm. Thought process is if you miss something, let's say like an antecubital, and you blow that vein, theoretically, if you start an IV down here, you've already sort of disrupted the venous circulation here, and so you could just be infiltrating any of the medications you're giving more distally into the soft tissue up here as it reaches that vein that you've already punctured. Stay tuned for part 2, where I talk about different interpersonal skills that you can bring to the table, especially when you're working in a team-based setting like in the operating room.